Hello everyone. So we've now seen how to repair infective endocarditis from the A3P3 commissure, the A1P1 commissure, the posterior leaflet, and the anterior leaflet. Sometimes in cardiovascular medicine, we implant devices. One of the most common these days is the implantation of left atrial appendage occlusion devices performed via catheter or percutaneously. This is used to treat atrial fibrillation, and in the case we're about to show you is when that goes awry and gets infected. So we're going to talk about explantation of the device and a biatrial Cox-Maze procedure. Let's take a look. This is a complex patient who presented with frailty and required a left atrial appendage or Watchman device at an outside facility, but this was complicated by an acute infection, and the patient presented with this large vegetation and an acute embolic stroke. Given the patient's acute illness, it was felt that a sternotomy approach was less than ideal, and a robotic approach was utilized. As we can see, upon opening this very large endocarditic vegetation, which was carefully and initially debrided, we could see the pus that was required to be evacuated from this abscess cavity around the implantable device. Once swabbed, it was then carefully and meticulously debrided in a stepwise fashion. Now, this can be excised, much like we had demonstrated in a previous video of the non-infected or mal-deployed Watchman, in a similar way using blunt dissection. You can see in this case, it was fairly well incorporated, albeit infected, and we can just carefully excise this. We have to make sure that we maintain the integrity of the left atrial appendage, of course, but this can be extricated in a blunt and careful manner. So here we see the Watchman device now carefully being maneuvered from the atrial appendage tissue. In this case, thankfully, the infection seems to be contained in this abscess cavity. The device is then withdrawn, and completion debridement is now undertaken with devitalized tissues being resected with a combination of blunt and sharp dissection, as you can see. And this follows the principles of all surgical abscess drainage principles of infected material. So first, remove any and all devitalized tissue. And once that's cleaned and debrided, then we address the residual cavity. Now, of course, I'm sure one can understand that once you've crested the learning curve in a robotic approach, it becomes routine, and these types of cases can potentially even decrease the predicted morbidity of patients such as this. We put a little antimicrobial material in the cavity. We irrigate the cavity thoroughly. And now that it's cleaned, we proceed to treat the primary problem, and that is this patient's atrial fibrillation. So an epicardial coronary sinus lesion marking the area, followed by the inferior box lesion for the left-sided lesions for the Maze procedure that we've demonstrated previously, the superior box lesion, the mitral line directly opposite the coronary sinus lesion, the tricuspid completion line after the vertical atriotomy, the SVC line, followed by the right atrial appendage line, and the IVC line. Now, once the maze procedure is complete, we then proceed to obliterate the cavity with 2 layers of endoatrial closure with polytetrafluoroethylene suture. And occluded. Now, the patient had a residual patent foramen ovale, and this was closed in a running fashion using this monofilament suture that we have demonstrated previously. Now, given the patient's tricuspid insufficiency identified preoperatively, a suture annuloplasty of the tricuspid annulus was performed. Given the patient's sepsis, we elected to perform this technique. And upon weaning from cardiopulmonary bypass, the patient has no residual tricuspid insufficiency and a completely occluded and obliterated left atrial appendage orifice. So now we've seen how to reconstruct mitral valves in the setting of infective endocarditis, A3-P3 commissure, A1-P1 commissure, posterior leaflet, and now even anterior leaflet. If we reflect back for a moment of all we've done so far in the series, we've talked about the fundamentals of starting a robotic heart program and stepping through each stage of mitral valve complexity and the treatment of atrial fibrillation. And now for our next season, I'm very excited to share with you our approach to the aortic valve with a technique that we developed known as robotic aortic valve replacement, or RAVR, done through a minimally invasive transaxillary incision. Hope to see you then.